Hello everyone, my name is Jen and today I'll be presenting on my case. So this is my client. She's a 38-year-old female who worked as a domestic helper in Singapore, and on 29th of April she actually suffered a stroke, a right ACA and MCA infarct, and then she did a decompressive hemicraniectomy and we saw her 3 weeks later in the rehab ward. I'll be using the PEO model. So for her person, these are her roles, and she also presents with cognitive deficits, and for spirituality, she prefers to do things by herself, and she values her appearance as well because she's still very young, and she also values her family where she will video call them every day. This is her physical components where she has left-sided neglect with a right gaze preference. She also has a loss of light and deep tactile sensation over the left upper limb. She also has tight neck muscles that are laterally rotated towards the left side, and she also has a flaccid left upper and lower limb, and she presents with Pusher syndrome as well. For the environment, the culture is that stroke condition is actually quite uncommon among peers of her age, and we are looking at the hospital rules and routine, and the physical environment will change when she returns back to Philippines for her long-term care. Then for the social environment, we are looking at the employer who's a main source of support here, and he crowdfunded around $30,000 online so that this can prepare her for her care back home. For the occupation, we are looking at mainly the ADLs, where her eating is at supervision level. She just got upgraded to a normal diet. And then for upper body dressing is actually moderate assistance, lower body dressings, maximum assistance. Toileting is that she's still on diapers. And then for her transfer, she's actually moderate assistance from high to low surfaces. Now I'll be talking about evaluation and goal setting. These are our priority areas where we want to value hygiene and appearance because her diet actually just got upgraded, and we want to look at oral hygiene. So we'll be looking at brushing of teeth, and because she's actually returning to the Philippines soon and the airplane flight is around 3.5 hours, so we'll be looking at transfers and sustained sitting. We did a performance analysis for brushing of teeth, and she has difficulty in setup with one hand. She displays random sit strategy, left upper limb hanging on the side of the commode, and she also has poor sitting posture. For the bend pivot transfer, she actually pushes towards her weaker side and is unable to stabilize herself independently. She also has poor midline alignment in terms of her head and neck control, and she also has poor positioning of both upper limbs. Again, she also has poor sitting posture. So now we'll look at the problem statements. So M has difficulty brushing of teeth due to the person occupation feat. Like for example, the reduced perceptual abilities from the neglect, the reduced sitting balance, and poor positioning and protection of the left upper limb. Also, there are the tools available as well in the occupation environment fit, whereby right now she's not using any tools to help her. So hemiplegia has the potential to deteriorate function of trunk muscles on both sides of the body. So this could be the reason why she has reduced sitting balance as compared to premorbid status. So these are the goals. We will have two long-term goals for this problem statement. The first long-term goal will be the hemiplegic method, where we want her to brush teeth with modified independence without setup. The next one will be visual scanning, where we want her to apply the visual scanning technique without any prompts. So next problem area would be the transfers and sustained sitting. Again, is due to person occupation feat because of the reduced sitting balance like we mentioned earlier, and also the poor positioning and protection of her left upper limb. As well as this sitting balance is also due to the impaired midline awareness because of the pusher. So for the goals, we'll be looking at bend pivot transfer itself from the unaffected side. We want her to actually transfer with minimum assistance for all types of surfaces, either high to low equal surfaces or low to high. And we're also looking at pressure relief for sustained sitting, where we need her to apply the technique as needed independently and sustain sitting for at least 3 hours in any chosen activity. Now we'll be looking at the interventions. So for brushing of teeth, we will try to improve the person environment occupation feat, and we found that improvement in trunk control has led to improvement in upper extremity function for functional activities. So under person, the biomechanical frame of reference, we will want to work on the trunk control, like for example, train the core stabilizers or weight bearing of the left upper limb to help in the core activation. Also be working on cognitive perceptual like visual scanning, or we'll be trying out a toothbrush stand or the use of a cup and a mirror to align her head and neck, as well as the occupation we were exploring the one-handed technique. So for transfers, again, to improve the PEO fit, we also found that we want to develop control of balance and movement on an automatic basis. Then this will allow a control of functional movements. So for example, if her balance is actually there, then we can actually work on her reaching towards the armrest for transfers. So for person, we'll be working on the core stabilizers. Then for the environment, we can explore the use of a sling. And occupation wise, we can actually look at caregiver training for transfers and actually practicing the transfers and pressure relief. So this is a sample session where we combine the two interventions that we want to do. So again, you can see it's mainly biomechanical and motor control frame of reference. So for example, like passive ranging, active ranging, bed mobility, transfers, upright sitting. And then we'll go on to maybe a tabletop activity, which is the visual scanning part. And then we will end off with transfers and pressure relief. So for gradation of the sessions, we will actually look at the different chains, for example, closed chain to modified closed chain and open chain. And we want to actually look at different surfaces as well. So for example, gravity eliminated horizontal surfaces like wiping of a table compared to vertical surfaces like wiping of a window that is against gravity. So all these will be adjusted and graded during the session based on her capabilities. So I have actually decided to focus on the biomechanical frame of reference, and from there I choose to look at neurodevelopmental treatment, or known as the BOBAF concept. So this actually looks at breaking down skills into sub-skills and analyzing components of tasks and the environment. So this is seen in the performance analysis and the PEO model. Also for NDT, trunk is actually the main important thing in treatment for hemiplegia, where they said that you need fine trunk control and proper weight transfer to protect the body, then we can achieve this third functional movement. So I'll be looking at evidence-based practice based on this hierarchy of evidence. So we will look at background information, which is our textbook. So in this textbook, it talks about how BOBAF will look at head and neck control in terms of maybe weight bearing on the unaffected side. Then you align your head and your neck. And then they also talk about postural control in the middle. Then it will then branch up towards distal movement. It also talks about upright sitting in terms of facilitating the trunk on how to sit upright, and as well as scooting inwards and outwards for lateral flexion of the trunk. So they both also talk about how we can actually do weight bearing of the upper limb, and this can actually help to increase the trunk control and can even be done with patients with severe weakness and loss of motor control as well. So next, NDT therapies also look at the assessments that they use, which is functional reach and work balance skills. So this will be the assessments that I'll be looking out for when we go on to RCTs, when we look at the outcomes measures. So this is my PICO table. So P is stroke patients, I is NDT, C is other methods, and O will be like balance and activities of daily living. So under the RCT, we actually look at, this study looks at BOBAF therapy versus physiotherapy strengthening and stretching exercises. Again, the clinical outcomes as mentioned earlier is the work balance test and the functional reach test. So they found that BOBAF actually improved trunk performance, balance, quality, but it's only in pre-post setting, and it's not, there's no difference between the groups of BOBAF and physiotherapists. And this could be actually due to a small group sample. However, there's also an absence of power analysis, so it's very hard to tell actually how much improvement or effect is there, whether is it small, moderate, or large. The next one is actually a BOBAF therapy compared with other therapy, again looking at functional outcomes and posture in terms of weight symmetry over both sides of the body. They found that BOBAF is most effectively short term, but only 29% of them are able to retain these techniques taught. So again, BOBAF can be effective, but it may not be effectively long term. Next, systematic review, our last evidence, and then it's about balance and ADLs following stroke, and they found that NDT is actually not superior to other approaches. Then for our last systematic review, it actually looks at all kinds of therapies and improving balance, and they found that 61% talk about physical therapy, but it does not include BOBAF technique as well. So overall, there are still mixed evidence regarding BOBAF technique, and NDT actually has no constant definition and practice that's easily studied. And these interventions are actually individualized like in the RCT and based on the BOBAF principles. So therefore, it's very hard to apply in a clinical setting. However, to request for a standard practice is also paradoxical as well, because there's no standard approach to meet the needs of all individuals. Lastly, my patient is actually 38 years old, and she's actually a young stroke patient. However, there is little to no more evidence regarding young stroke patients versus elderly stroke patients in the area of NDT, and we also have to consider the fact of neuroplasticity as well. So therefore, instead of purely focusing on one mode of intervention, we can take the elective approach and use other intervention to complement areas. So this could be functional approach like teaching our patients to move following the loss of motor function. So here are my references. Thank you.